talk. I'm going to talk today a little bit on heart valve replacement and repair surgery, but more leaning towards a different way of doing it with smaller incisions that may be less traumatic to the body and lend itself to quicker recovery. Let's see. As you know, the heart basically is the pumping organ of the body and basically pumps blood out of it into the lungs and then out again to the body. It's then returned to the right side of the heart, where it then is returned to the lungs to get oxygen, and that way we're able to function on a day-to-day and a minute-to-minute basis. There are two upper chambers of the heart and two lower chambers of the heart. The atria, or the right atrium, left atrium, are sort of the collection chambers for the right and left sides of the heart. And the right side collects blood and sends it to the lungs, and after the oxygen is basically exchanged there, then it's pumped into the left side, where then it goes off into the body and again nourishes the rest of our organs. As you see, there are four heart valves in each person's heart. The heart valves have to open and close, and I like to tell patients it's like a door. The door should open all the way, close all the way, but occasionally what happens is one of these doors may get stuck in the open position, or it may get stuck in the partially closed position. And either way, the blood is not getting passed through the heart properly, and therefore the heart has to work overtime, and that can lead to what's known as an enlarged heart, which is one of the signs of heart failure. These are the various valves. The most important, the ones that we talk about here, basically the pulmonary valve we really don't talk about, because that really doesn't give adults problems. Pediatric patients, congenital heart surgery patients will have pulmonic valve problems. We're talking more about the mitral valve, which is very important to basically take blood from the lungs and then send it to the left ventricle and then out to the body. The tricuspid valve, which is on the right side of the heart. And the aortic valve, which is at the end of the heart before the blood goes out into the body. The aortic valve and mitral valves are especially important in patients as they get older, because these two especially are prone to giving us trouble as we age. It's just another picture. The pulmonic valve, which you really don't talk about because it doesn't give adults problems. You got the tricuspid valve, you have the aortic valve, and the mitral valve. And as you see, the blood comes in through the right atrium, goes across the tricuspid valve, gets pumped it through the pulmonary valve. This is to depict the pulmonary arteries, which go to the lungs. The blood then passes back from the lungs into the pulmonary vein, into the left atrium, across the mitral valve, and then it's pumped out through the aortic valve and then out to the body. As I said before, the valves have to open enough to let the appropriate amount of blood pass through them. They have to close tightly so there's no blood leaking out, and they have to be properly formed, and they have to be flexible. Typically, when we look at these valves, if we look at a normal valve inside a normal functioning heart, the valve leaflets, as they're called, are about as thin as wet tissue paper. You can almost see through them. If they get into trouble, a lot of times they get very thickened, so they almost look like white leather, and they have sort of the consistency of sort of wet leather. They're just not real loose. When you hear the word stenosis, that means that the valve, no matter what valve it is, it's too tight, or it's not open completely, so the heart has to push extra hard to push the blood through that tight stenotic or valve, or valve stenosis. When you hear regurgitation, that means the valve isn't closing all the way, or when it does close, it doesn't close it basically closes in such a way that blood passes back through it, so the blood's going to go in two directions. These valves have to be sort of one-directional. It's just basic plumbing. Go back to this. You might have heard of mitral valve prolapse, which is just one of those situations where one of the valves, the mitral valve in this case, doesn't close properly, and a lot of people will have a little bit of mitral valve prolapse that never really progresses, but sometimes it does, and in fact it can progress to the point where patients develop significant amount of heart failure with this, and they need to have that valve repaired or replaced. You can have single valve defects or double valve defects or even triple valve defects. In other words, where all of the major valves are badly damaged for a number of reasons, and then those have to be dealt with, or else you go on to fairly significant heart failure, which basically means you're short of breath all the time. You go up and down the stairs and you're short of breath. You can't really walk around your house without getting short of breath, and that can be an indication of significantly bad heart failure. As mentioned here, these conditions can happen at birth, and then they sort of sit quietly until we're well into our 50s and 60s and 70s, and then they become a problem. Treatment options vary depending on which valve is the problem and how bad the problem is, but as it says here, typically with severe cases of valve problems, surgery is usually indicated to repair or replace that bad acting valve. The treatments include valve repair or replacement, usually through what we call an open procedure or sternotomy, where we go through the breastbone. The entire length of the breastbone has been the typical way to do that. But nowadays, there are some minimally invasive options where we make smaller incisions in the body, on the chest, and sometimes we don't even go through the breastbone at all, and the recovery is much quicker. Patients bleed less, they have less pain, and they get at least as good of results as they do by going through the breastbone. I tell every patient the same thing though. Even if we make a small incision, it's still going to hurt. These are not painless operations. You're still going to go home on pain medicine. You're just going to go home on less pain medicine. You're going to be less limited by the pain you have because it's just a smaller incision. But these are not painless incisions. I talked about the sternotomy incision. This is an incision basically down the entire length of the breastbone. We saw through the breastbone, and then when we're done, we wire it shut, and those wires stay inside the body forever. You really don't notice them. You might see them on an x-ray someday, but you don't really notice them. That's not a bad incision. That's a great way of doing heart surgery, but we found that there are maybe some ways that are better in terms of quicker recovery. One is to go through just the top third of the breastbone with a saw, and then we basically we're able to get in with smaller instruments and do our operations on the aortic valve through the smaller incision. Another way is to not even go through the breastbone, but go to the side of the breastbone on the right side up in the front, sort of about 4 inches below the collarbone, and that's another way of getting at the aortic valve. Again, we don't go through the breastbone at all. With the mitral valve, we can go through the side, and the incision is shown here, but actually the incision is almost in your armpit, off to the side, off to the left breast, just about where the left breast and the armpit join, and that's a very nice way of seeing the mitral valve, which is that's the incision we use to get to the mitral valve. This just shows a lot of the incisions. Initially it was incision all the way down the front, and then there's incisions where you come a third of the way down and, as we say, tee it off, or a J incision where you come down and make a J incision, or you come up from the top and make an upside down J. There's a lot of different ways of doing these operations, but without going through the entire breastbone, which again leads to less pain but not no pain. Again, these are the incisions we use today sometimes to do an aortic valve replacement. We go through the incision up here in the front, near the breastbone but not through the breastbone. The mitral valve incision, again, we go more on the side by the armpit and sort of underneath and to the side of the or right breast, I should say. Again, not going through the breastbone at all. In the past, This is what we would be set up with. We would do the incision through the whole breastbone. You can see the whole heart, put a bunch of tubes in the heart to connect it to the heart-lung machine. And nowadays you can do the same operation through a little incision here on the side, which has got to hurt less than this incision. Some of the tubes, instead of being hooked up to the heart here, we hook them up sometimes in the neck and always in the blood vessels in the leg. This is the past. Again, here's somebody with a full breastbone incision. And now this is an incision on the right side of the chest, underneath the right breast. And see, we don't even have to go through the breastbone, which is over here. In order to do this operation, you have to be able to do it as well through the smaller incision as has been done through the full breastbone incision. Because if you can't do it as well through the smaller incision, you're either going to end up with a poor result, the patient comes back with needing repeat heart surgery, or you're not doing it as safely, and obviously safety is our first concern with any heart surgery operation. This report basically says that you can do these operations through smaller incisions. The patients in general tend to stay in the hospital 2 to 3 days less. They're in the ICU usually 1 to 2 days less. They're on the respirator after surgery less. They may have to be on the heart-lung machine longer during the surgery, and they may have a longer time that the heart is stopped. But those really aren't significant given that we have good ways of protecting the body and the heart while we're actually in there. This just shows how we can hook you up to the heart-lung machine. Remember that other incision that we had, the full incision down the breastbone, hook up the heart-lung machine through the open chest here. Nowadays we have special tubing and cannulas, we call it. We can hook people up to the heart-lung machine through a small incision in the groin area, and then do our whole operation through this little incision over here. Again, these just show the incisions for the different operations. This is a picture. We don't use robots, we don't use scopes. We just make a small incision. This is sort of the armpit area. The arm's over here. This is sort of the patient's side. The breastbone's up there in the front. And this is the incision, the hole, as you will, that we're working through to see what we're doing to fix the heart. As I tell people, too, operating through this incision is sort of like operating through imagine a cardboard tube that comes in the toilet paper, and it's about that size. That's about the size of the hole that we're working through. But with the instrumentation now, it's been perfected to where we can do these operations through those little incisions. Here's sort of an artist's drawing of what we see to get to the mitral valve. Again, that's sort of about the size of a cardboard tube from a toilet paper roll. This is an incision for the aortic valve where we go up through the front but not through the sternum, and this is what we can see, again, with a much smaller incision. You can do other operations with these small incisions. You can fix that tricuspid valve. You can take out tumors of the heart. An atrial myxoma is a tumor that is benign but is not uncommon, and we can do that through the small incision. People sometimes are born with a hole in their heart, and that can be done through the small incision. Sometimes people have atrial fibrillation and need what's called a Mays procedure. We can do through the small incision also. Patients who are not candidates for this operation include people who have very, very calcified blood vessels or aneurysms or abnormal bulging of their main blood vessels, because those it's dangerous to try and do the operation with those conditions. The patient can literally bleed to death from any of these or have a major stroke from the calcium breaking loose. So we tend to avoid those small incision operations for these patients. Also, if people have had some sort of infection or inflammatory process in the right chest in the past, we avoid making those small incisions in the right chest because that can become very problematic during surgery. And as people like to say, the minimally invasive valve surgery, we're transferring the pain and discomfort from the patient to the surgeon. And it's very true. The operation is much more technically challenging through the small incision, but the benefit is the patient recovers more quickly, does not need as much pain medicine, usually goes home quicker and is back to work or to their daily life much sooner. People have noticed there's less pain and trauma. We give less blood transfusions, less wound infections. Like I said before, reduced recovery times. We see better cosmetic results, and there's been no real difference in the complications with this operation. And one of the big complications is breastbone incision complications. And since we're avoiding going through the breastbone for the most part, we're just avoiding that whole set of problems in the end. That's it. That's all. Any questions about any of this?